Hi, I'm Desiree Summers, and today I'm going to do a training on accounts receivable, insurance billing, and collections. So the first part of this training, I would like to go over with you guys the life cycle of a claim. I feel like it will help give you a better understanding of how the whole billing process works, as far as the start of pre-registering the patient, checking out the patient, and then where the billing starts to take place. And it gives you kind of an inside look of how the whole process works within our physician's office. So the first part of the life cycle is pre-registering the patient. Then we have established financial responsibility. We then check in the patient. We review coding compliance. We review the billing compliance. Then we check out the patient. We prepare and transmit claims. We monitor payer adjudication. We generate patient statements. And then we follow up with patients and collections. So the diagram represents, as I mentioned, the life cycle of the claim. It's always a good idea to see how the life cycle works so that you can see or have a better understanding of what leads to the AR, insurance billing, follow-up, and collections process. There are 10 steps to the claim cycle, as I just went over with you. The first step is pre-registering the patient. In this process, the secretary at our office will need to obtain information from the patient, such as the reason for the visit, insurance information, and their employment status. In step 2, we want to establish financial responsibility. In order to do this, the secretary will need to contact the insurance provider to determine what the insurance will cover, and what the patient's responsibility will be. So this will let them know whether the patient will need to pay out of pocket at the time of visit for a copay or a deductible. Once everything is verified, then the secretary will then check in the patient. In this process, our secretary will need to know if the patient is a new patient or if the patient is a returning patient. A new patient is considered a new patient. They could have went to our physician's office maybe about 4 years ago. If that's the case, then we will consider them as a new patient because they haven't been in our facility for a long time. And a returning patient is one that has been established in our office and is a regular patient. So if the patient is a new patient, they will be required to fill out all the paperwork that entails all of their information, including medical history. Once the patient is checked out, our medical coder will determine the diagnosis and the procedure codes, and then assign the correct codes. And step 5 entails the review of billing compliance, in which our coder will determine if medical necessity was met. So a lot of times if it's the medical necessity was not met, the insurance company will not cover the charges, so that's a very important step that needs to be taken. So once that is done, then it's time to check out the patient, which is what the secretary will do. Once the patient is checked out, the AR worker will then, which will be you guys, will then fill out the CMS 1500 form with all the patient's information on it that is needed to submit the claim. Once the claim is filled out, you will then submit the claim for reimbursement for services that were rendered. You will then check the claim status to see if the insurance company denied, processed, or rejected the claim. You can then print out an explanation of benefits that will reference how the insurance adjudicated the claim. In other words, how the insurance processed the claim, whether they denied it or if they made payment for it, or if there's patient's responsibility, whatever the case may be. So in the last step, you will continue to follow up on the claim to collect the money from the insurance company or the patient. So this is like in a case if you haven't received the money, you'll just keep continuing to follow up until finally a decision has been made on what the insurance company will do regarding payment. So the life cycle of the claim is kind of a very important process in our company. It's how everything works. It gives you an idea. It's when you first start AR, it can be a very overwhelming, and it does help knowing exactly how the whole process falls into play. So next we will move on to our next slide. So in the next part of our training, I would like to talk about the different types of insurances. There are tons and tons and tons and tons of different types of insurances, but we're just going to kind of pinpoint main insurances that we deal with on a daily basis. So we have our Medicare, which is one of our biggest payers. We have Medicaid. We have commercial insurance, which will be things like your United Healthcare, AARP, and it's your private payers pretty much. You have your TRICARE and you have your CHAMPA. So, as an AR worker, it's important to know, as I said, the different types of these insurances so you can know their processes and how they work as you're billing for them. And again, it will take time to learn all of these processes. It'll take time to learn how the insurance company works. Once you get further into the AR process, you'll start to realize what different insurances are going to pay, like what their allowed amounts are, depending on the procedure codes that were billed. So it's very, very important to know what insurances you're dealing with and what to expect. That way, if you also receive denials for insurances and you don't believe that they should deny that, then that's when we can start like an appeal process, which we will go into later on in this training. So there are different, so as I stated, there are different types of Medicare. So you have your Medicare A, which covers your inpatient and hospital stays. So this insurance is not useful in our office as we are outpatient physician office. This would be more for if the patient needed to be seen in the hospital, then they would need to use their Medicare A coverage. If they need to stay in the hospital for some different type of illness they have going on. We could have referred them to the hospital because say if the patient had some kind of illness going on where they need surgery or something like that, we can refer them to go to the hospital in which their Medicare Part A would be applicable in that situation. So then we have Medicare B, which provides outpatient medical coverage, which can be used at our office, and it can also be used at the hospital. If the patient goes to the hospital just for, say, if a patient has to have a DNC done, we refer them to the hospital. They got to get their DNC done. It's considered an outpatient procedure, so their Medicare B will cover that as well, and it will cover any medical coverage or medical expenses that went along with that, along with what we charged in our office for any services that we needed to do as far as checkups go with that DNC and everything like that. So then we have Medicare C covers both Medicare A and B. So it can be useful for outpatient and inpatient services. So they kind of bundle together. Medicare C is also referred to as a Medicare Advantage plan. So sometimes the patients have a lot of different options, where they can go. Medicare C does have usually higher premiums for patients, considering that it offers a lot more as far as where they can get services done. And then there is Medicare D, which is the patient's prescription drug coverage. So normally patients with Medicare A and B will have Medicare Part D. May not always be the case, but a lot of the times that is the case because, when you go to your hospitals or when you go to your physician's office, you're going to want to have that prescription coverage, or the patient's going to want to have that. So their prescriptions are going to be less costly. So, and then, which The Medicare B obviously does not affect our office, considering we bill strictly for services that were rendered, and we don't bill for prescription drugs. And it is also important to note that a lot of times Medicare is your primary payer, and they will cover 80% of the services rendered. So either the patient, or if the patient has a secondary coverage, the patient, or I'm sorry, either the patient or if the patient has a secondary coverage, they would be responsible for the remaining 20%. If the patient doesn't have the secondary coverage, then obviously they would have to pay the 20%, which they would be billed out for. The next insurance I would like to mention is Medicaid. Medicaid is considered the final payer. A lot of times there are laws in place where a patient cannot be billed if they have Medicaid. So, there has been certain circumstances where the Medicaid hasn't been added into the patient's account yet. Maybe it could be a situation as the patient forgot to update their information, so the bill went to the patient. Well, of course, the patient wasn't happy because they're like, we're not even supposed to be getting billed for this. This is Medicaid. So we would then look into their account, we'd add the insurance, and then we would move the money to Medicaid. Medicaid sometimes will have co-pays. They don't usually have co-insurances, but the co-pays are very small. We've seen co-pays anywhere from 50 cents to $10. They're usually relatively small, and the patient will be responsible for paying that copay in the office. So, and then the other one, insurance, is your commercial insurances, which are private payers, which include your AARP, BCB, or Blue Cross Blue Shield, also known as BCBS. We have United Healthcare, and there are many more. And as the farther you get into AR, you'll come across a lot of different commercial insurances, and you'll be able to differentiate the differences between the commercial insurances, your Medicaid, and your Medicares. So, and then we have our TRICARE insurance, which is provided for uniformed service members, retirees, and their families throughout the world. We have our CHAMP VA insurance, which is similar to TRICARE, pretty much the same type of coverage, as it covers the cost for the uniformed service members and their families. So here's now we went over the different types of insurances, so hopefully this can kind of give you a better understanding and a kickstart to starting your AR career. So this part of the training, before we get into our AR and collections, I wanted to go over with you guys regarding HIPAA. HIPAA is the Health Insurance Portability and Accountable Act. It's very, very important that we always follow HIPAA guidelines. So let's talk a bit about that, so we are understanding exactly what HIPAA covers and what rules we need to follow to make sure that the patient's information is always protected. So one important thing with working with medical claims is understanding the protection of the patient's information. That's like one of our main goals. You want a patient to always feel like that their information is not going to get out to anybody else, which, I'm sure you would not want your information out to just anybody as well. So we would use the same, guidelines. So HIPAA is, as I mentioned, the Health Insurance Portability Accountable Act. It's a federal law that has introduced standards in healthcare relating to patient privacy and the protection of medical data. HIPAA covers healthcare providers, which would be us. It covers health plans, healthcare clearinghouses, and business associates of HIPAA. The HIPAA privacy rule covers all individually identifiable health information that is created, stored, maintained, or transmitted by HIPAA covered entity or a business associate of a HIPAA covered entity. The HIPAA privacy rule applies to all forms of personal health information, which can be abbreviated as PHI. including paper records, films, which could be x-rays or, in that sort of line, and electronic health information. It covers even spoken information. So let's say you were on the phone discussing personal health information. You will need to make sure you are not discussing that information to where someone from outside our facility can hear it, such as a patient. Obviously, you can see how that could be a problem because, say, if you're on the phone, you're discussing, hey, the patient had to have a appendectomy done. You don't want another patient to hear that, or even if you mention the patient's name, that's a breach of a HIPAA violation. We don't want that to happen. So HIPAA is also a reason why when you look at a claim, there are procedure codes or diagnosis codes on a claim instead of the actual written out diagnosis. The insurance company reading the claim can look at the codes and know what was done. However, if someone outside of the healthcare industry gets a hold of that claim, they will more than likely not know what those codes mean. But our job here is to make sure our claims do not get into the wrong hands to begin with. There are several healthcare facilities that unfortunately have been sued, and they were in the paper due to a HIPAA breach, and we do not want to be one of those companies, which is why we always want to follow HIPAA guidelines. We will have to complete a HIPAA training, or you guys will have to complete a HIPAA training once a year. And once you start your first day on the job, you will need to become HIPAA certified. In order to become certified, I will send you the link via email, in which you will then log onto the website. You go through the training and answer all the questions to receive your certification. Once you receive your certification, you will need to send me a copy of it via email so I'm aware. This will be one of the first things you will do before you start working on your claims. A few things I would like to point out as well is the benefits that HIPAA gives to our patients. It gives our patients peace of mind that their information is protected and secure, which is very, very important. Because I'm sure you as a patient will want to have that peace of mind as well. So the patient is able to receive a copy of their health information through HIPAA. And also, if by chance there happens to be a breach, we will need to make the patient aware of the breach immediately if they're affected by it. So these are pretty much the rules with HIPAA and how to summarize, it's all about patient privacy. We have to make sure that all the health information is protected. We do have secure websites. Our computers are secured. When we send things via email, they do go through a secure message. That way, the only person that can open up that message is the person that is receiving the message, which is very important. I will talk a little bit more about HIPAA as we go along throughout this training. So another part of this training is I would like to talk about the clearinghouses, as this is an important process of submitting the claims. This is the place where the claims are submitted to. The clearinghouse will check the claims for errors. The claim will be sent back if rejected or denied. And we go through Zermed as our clearinghouse. So Zermed is a website that we log into, and we can also submit claims to it. So a medical clearinghouse acts as a middleman between us and the provider and the payer, or between us as a provider and the payer. The practice management software on a billing professional's computer creates an electronic file. This file is then uploaded into our medical billing clearinghouse. We go through a clearinghouse, as I mentioned, called Zermed. We submit our claims electronically to them, where they would then check for errors and verify that the claim is compatible with the payer software. Due to the potential difficulties caused by incompatible software, which we've had in the past, we were required to complete and an initial enrollment period prior to sending the claims for the first time. So when we first signed up with the clearinghouse, it did take quite a bit of time, but in the end, it's really worth it. So, but yes, it was definitely a timely process. Our clearinghouse will also make sure that the procedure code is appropriate with the diagnosis code submitted with it. Going through the clearinghouse helps prevent time-consuming processing errors. Basically, the clearinghouse is our cross-checks to make sure all of our information submitted is accurate before the bill is sent to the insurance company. If the claim does come back as rejected, the clearinghouse will state the issue, in which we can then submit a corrected claim with the fixed issue. It could be something as simple as not putting in the patient's date of birth. If the patient has no errors, then the clearinghouse will securely transmit the electronic claim to the payer, in which it is already established a secure connection that meets the strict standards laid down by HIPAA. Clearinghouses also have other useful tools for our payment posting side of it. This is actually how all of our claims for payment posting, anything that comes through on Dermot, our clearinghouse, a lot of the times we are able to get it to come through the system, like through our software, our posting software. We'll get it to come through there as electronically. So that way, all the payments that the posters post, they're able to post them electronically versus having to post them manually, which is a very good thing to have as well. So now let's move on to the next part of this training. So now I would like to go over in this training the accounts receivable, which is also known as AR, which is what you guys will be doing. So with AR, the revenues are generated but not yet collected, meaning that the billing forms are submitted, but we haven't collected money on it yet. That's the first step. So, and then we'd have follow-up. We have preventing fraud, waste, and abuse, which is, what we want to make sure that we avoid that. Maintaining patient privacy, staying within the collection period, and maintain professionalism. So accounts receivable, which is also known as patient's account, is the process of billing and following up on a claim to receive payment for services that were rendered. After a patient has been seen in our facility, then it is the job of the AR worker, which would be you guys, to bill the insurance company for the charges. Now, even as I talked about earlier, before the insurance company actually gets billed, it will go through our clearinghouse for them to check for errors, and then we'll go through that whole process to see if we need to correct anything before we can submit it back and it goes to the insurance company. So if the patient does not have insurance, then the patient will need to pay for services up front to ensure that we are receiving our money. When the patient receives treatment at our facility, that's when the bill is then generated and submitted to the clearinghouse to check for errors, and then to the insurance company electronically. Submission of the claim electronically will ensure that we will either receive reimbursement in a timely manner, or if the claim is rejected or denied, we will have the ability to correct the claim or look further into why the claim was denied to see what we need to do to get that claim paid. This is the main job of the AR worker. I would like to point out some important information that comes with working with medical claims. One of our main goals is to prevent fraud, waste, and abuse. In order to do this, you as an employee will need to make sure you are billing for claims that were truly rendered. An example of fraud is billing for services at a higher rate than is actually justified. So if a patient is seen in our office for a well check, we want to make sure that that is all they're getting billed for. We don't want any extra charges on there. Fraud is a very, very serious thing in the medical billing industry. and we want to take every step possible to avoid that, and we should not be doing that. We are a professional field. We should always do everything professional and make sure we're only billing for services that were rendered. So, it's also unethical to bill for services that were not rendered, and it's unaccepted in our office to charge the patient or insurance company more money for services they did not receive. When I talk about waste, I am talking about the misuse of services or overutilization of services. If a patient is seen in our office, we do not take advantage of the insurance company by doing additional tests or procedures that are not necessary. So if a patient's seen in our office and they just want to have, like, maybe they're sick, they got the cold, they got the flu, whatever, they're coming in there for, they have symptoms of a cold, and we diagnose them with the flu. But then because of their insurance, a doctor's office might feel like, well, hey, let's go ahead and take like a strep test, even though there's no signs that the patient is even, like, there's no sore throat, there's no signs that the patient would even have strep. They went ahead and did this extra procedure so they can charge the insurance company for it. That's an example of waste. Like, we don't want to take advantage of the insurance. We want to do what we need to do to diagnose the patient and to make sure it's medically a necessity. So, when I talk about abuse, that refers to charging an access for services or supplies, or billing for items or services that should not be paid for by Medicare or Medicaid. So, as I stated before, we are only to bill for services that are rendered and that are truly owed to us. Any instances of fraud, waste, or abuse will result in some sort of consequence, so you will face as an employee, depending on the circumstances, and whether we find out if it was deliberate or accidental. Another important aspect when doing accounts receivable, or working with any patient claims for that matter, is that we as physicians' office need to make sure that we are following HIPAA guidelines and maintaining the patient's privacy. To follow these guidelines, any papers that obtain patient information needs to be locked up, or it is no longer needed. Or if it is no longer needed, we do provide locked shred bins where we have a shredding company come in about once a month to empty out those bins for those papers to be shredded. A lot of our claims go electronically, and we receive the EOBs. A lot of those we receive electronically now through the system, known as a Capario is what we refer them to. So we usually don't have too much papers, but occasionally, sometimes the insurance companies will send you a paper EOB and they can't come through electronically. So once the shredders come, they will empty out our bins and they'll shred them for us, so we won't have to worry about the patient's information being breached. We also need to make sure our computers are locked at all times when we are away from our desk. If we are on the phone discussing patient information, we need to be aware of our surroundings, that other patients that are in our office cannot hear our conversation. Now let's talk about the collection period. It is important to receive reimbursement within a certain time frame. Depending on the insurance company, we only have so much time to get claims paid before they go into timely filing, meaning we can no longer receive money for those claims because they are after the time frame period. This is money that we are losing, and we want to prevent that from happening at all costs. Overall, our employees here are expected to maintain a professional atmosphere while doing their job and handling patient claims. So now that we established the submission of the claims, in that process, I would like to go over the rejections and denials with you, and part of this training process. So part of the rejections and denials are part of the AR follow-up process. We need to figure out the steps needed to take the steps needed to take to correct the rejections or to try to get the denials paid. So, a rejected claim is one that contains one or many errors found before the claim is processed. These errors prevent the insurance company from paying the bill as it is composed, and the rejected claim is then sent back to us in order for us to correct it from the clearinghouse. A rejected claim may be a result of a billing error, or it could come down to a mismatched procedure code or ICD codes. Additional errors that we may get a claim sent back to us is if the AR staff puts down the incorrect patient information, such as the sex, name, date of birth, insurance ID number, and so on. In addition, the claim may also be rejected due to incorrect codes used on the billing form, duplicate billing, mismatched medical codes such as confusing ICD codes excuse me, with CPT codes. When a claim is sent, we have a certain amount of time to receive payment, or the claim can then be denied for timely filing. This is why it's very important when sending a claim that everything on the billing form is checked thoroughly to avoid rejections. Denied claims are claims that the payer processed and deemed unpayable. These claims may violate the terms of the patient's contract, or they may just contain some sort of vital error that was caught only after processing. So say if we submitted the claim through the clearinghouse and the clearinghouse didn't catch the error, say if it was a duplicate payment or something such as that, then the claim was processed as a denial because the error wasn't corrected. In that case, it can kind of be an easy fix. It could be sent back to us. We can correct it, send it back through, and get that claim processed. So, so payers will include the explanation of benefits, telling you why a claim was denied. And usually the explanation of benefits, we'll go over that later on in this training, and we'll go over the denial codes that you'll see at the bottom of the EOB that's sent over to us to determine what steps you need to take in order to get the claims paid. So many times we can appeal these claims and send them back to the payer for processing. Some denials, however, can be a simple fix to get the insurance company to process the claim and reimburse us for our services, which is what we want. We definitely want, to be reimbursed for our services. We put the work out there, so we need to get paid. So this could be because Medicare paid as primary, and the secondary, who we are trying to get to pay, or I'm sorry, this could be because Medicare paid as primary, and the secondary is who we are trying to get paid. However, the primary EOB was not attached, so the insurance denied the claim. In this situation, we could attach the EOB to the billing form and then resubmit the claim. So, another example of an easy fix is if the insurance company denies because they state the payer has a different insurance on file. This could be because the patient did not update their insurance information. If this is the case, then we would need to give the patient a phone call. We'd have them verify their insurance information over the phone. We need to get the policy number, the name of the insurance, and everything that we need in order to resubmit the claim. So that pretty much is your rejections and denials process. And as you get further along, you'll become more familiar with which are the rejections and what are the denials. And a lot of times the denials are from the insurance company. Rejections are just mainly the rejections that will be sent directly back to us from the clearinghouse when we submit it there to be checked for errors and things like that. So the next part of this training I would like to talk about is our AR age buckets. These are buckets that it's a guide that'll show us how outstanding a claim is. So our first age bucket, we have our 0 to 30 days. So we're still on a good part of our claim. This is the area where we want to stay in. I know a lot of times that's not always the case. It depends on really the payer and if they make their payments on time. And sometimes there are payers that are late at making their payments, so it puts us in a farther bracket. So then we have our 31 to 60 days. Bucket, which that starts to get a little bit farther out there. Then we have our 61 to 90 days, which is a red flag that we need to continue to try to receive our payment. So we have to pick up the phone, call the insurance company, try to figure out why we have not received payment for this. And it could be different situations. It could be either the payer is delaying on paying on the payment. It could be situations where claims have been denied and we've had to resubmit them, so they're still outstanding because they're still waiting to be reprocessed. So there's different things that fall into place to make your claims that far outstanding. And then we have the bucket for 91 to 120 days, which is very, very far for claims to be still outstanding. I've seen, cases where they're that far outstanding and it's the same situation where either the claim has denied several times or we're still trying to get paid or the payer is fighting us on paying the claim. So this is, again, we have to go back and forth with the insurance company to try to get these paid. Then once it reaches 121 days and over, that's when it's kind of scary for us because it will then be in the point two collections, meaning that we will end up selling the debt to a collection agency, so we would settle for less amount of money. So when this happens, it hurts our revenue. It will bring down our revenue. The longer the claim is, because we do invoicing, which is the amount of money that we take in per 2 weeks, and so the longer the claim is out there, the longer it's going to take us to get paid for services. So when we do invoicing, we're not getting as much money coming in as we should be. So our accounts receivable aging is a periodic report that categorizes our company's accounts receivable according to the length of time our invoice has been outstanding. We obviously, like I said, want to stay in the range of 0 to 30 days to collect our payments. This ensures we are getting our payment faster and we will get paid for the full services. Some payers we work with are considered late payers, so it takes more time for us to receive payment for our services. Once the invoices start going outside of the 30 days age bracket, this brings down the company's revenue because this is money that we are not receiving in a timely fashion. Our goal is to work with payers and to try to get paid for services within the 30 days to maintain our company's revenue. Like I said, we do invoicing about every 2 weeks, and invoicing is a crucial time for us because this will show what revenue is coming in and the money we are getting paid for. So, this is the way, if we are going months without getting paid for services because of delayed payments by the insurance company, then our revenue will decline significantly. Any claims after 121 days buckets will then be sent to collections, as I just talked about, which we might end up making a settlement with the insurance company or the patient to ensure we get paid for some money rather than us not getting paid for services at all. This means us bringing in less revenue. So when working your AR, it is important to keep track of the age brackets and get claims paid in a timely manner. We do not want to have claims out there that are outstanding and we are not receiving payments for them. The last thing we want to do is have to put a claim in collections because that will result in settling the debt to the collection agency, meaning that we receive less money to turn the debt over to the collection agency, as I just talked about. However, we do this in order to ensure we receive some type of payment, some money, whether it is less than what we are charged for, or some money, whether it is less than what we charge for, is better than nothing. So remember, as an AR worker, you want to use the AR age buckets as your guide to keep track of any outstanding invoices and to try and get payment for them as soon as possible to maintain a higher revenue. So in this part of the training, I'd like to go over our CMS 1500 form, which is our form that we use to bill out our claims. This form will need to be billed out accurately to prevent any rejections from the insurance company. This form is filled out based on the information you will receive regarding the patient's visit. At the top right, you will put in the name of the insurance company, the full address, including the state and zip code. In box 1, you will choose what type of insurance you are billing for. You have the options to check mark the box that says Medicare, Medicaid, TRICARE, TRANFA, Group Plan, which are commercial insurances, FECA, BLK, Lung, or other. So this is why I went over insurances with you guys in the beginning, because it's important to kind of know which ones you need to choose on that CMS claim form, because that something simple as that can also cause the claim to be rejected. In box 1A, you put the insurer's ID number. This can be found on the insurance card, also known as the policy number. In box 2 is where you would put the patient's name, starting with the last name, then first name, and then middle initial. In box 3 is where the patient's date of birth will go. In box 4, you would put the insured's name, which is only required if you're billing for an infant and using the mother's policy. In box 5, you need to put the patient's full address along with the telephone number. In box 6, you will put the patient's relationship to the insurer. If the patient is the one with the insurance, then you would choose self. Boxes 7 and 8 are fields that are not required. Boxes 9, A through D is also not required. In box 10, A through C is not required. Box 10D is not required. Boxes 11, A through B is not required. So as you can see, there are quite a few boxes in here that's not required to fill out to get your claim submitted. For box 11C, if you have Medicare or Medi-Cal crossover claims, then you would need to put in the Medicare carrier code. In box 11, you need to select if there's another insurance plan. Boxes 12 through 13 are not required. Box 14, you will need to enter the date of the patient's illness or injury relating to workman's comp. Box 15 and 16 are not required. Box 17, you will enter the name of the referring provider. This is only necessary if the patient is being referred to another facility regarding their diagnosis. So like if the patient, say, broke an arm and they need to be referred to an orthopedic, then that's when we would have to put the referring provider down there. In box 17A, you would enter the ID number of the referring physician if the patient is being referred. Then in box 17B, you would enter the referring provider's MPI. Box 18 only needs to be filled out if the patient was admitted in the hospital. Box 19 is only to be used if there is additional information required for procedures. In box 20, you only need to fill out if the patient was seen in an outside lab. In box 21A, you need to put in the final diagnosis code, in which the code you will be billing for. If you have additional diagnosis codes, you can put them in 21B through I. However, please note that these additional codes will not be billed on the claim form, on this specific claim form. They would need to be billed on different claims form for each diagnosis. Box 22 is not required. In box 23, you would put in prior authorization number if the claim needed to get prior authorization for the services that were performed. In box 24A, you would need to put in the date of service, which is when the services were rendered. In box 24B, you will put in the place of service code, which in our office, the code would be 11, which is a physician office code. In box 24D, you will put in your HIPAA or procedure codes. In box 24E, you would put in your diagnosis pointer, which would be your initial diagnosis that was put in box 21A. So you would put in A as your pointer. So in box 24F is where you would put in your charges. Box 24G is where you would put in the number of units that are being billed. In box 24H, you only need to fill this out if the services rendered were relating to a family plan. Box 24I is only billing for emergency services. Box 24J is where you put in your MPI of where the services were rendered. In box 25, you will need to enter your rendering tax ID number. In box 26 is where you enter the patient's account number. Box 27 is not required. Box 28, you will put in the total charge amount. In box 29, you will put in the amount that was paid by another insurance if applicable. In box 30, you will list the amount due. If nothing has been paid on it, then it would be the charge amount, would be the amount due. In box 31, you would need the signature of the physician or supplier. In box 32, you will enter the facility location. In box 32A, you will need to enter the MPI of the facility where services were rendered. In box 33, you will enter the billing provider full address along with phone number. In box 33A, you will enter the billing provider MPI. So the form itself is really self-explanatory. You will have all of the information you need in front of you to be able to fill out the necessary parts of this form so you can submit it electronically. Also note that this form will be filled out electronically as well. So now I'd like to talk about claim status and checking your claim status. So this is the follow-up on claims that were submitted. If available, we utilize the websites we have available to check the claim status to avoid having to call the insurance company. This is one of the Checking the claim status is one of the most important jobs you'll have as an AR worker. For this is like your main job besides submitting the claim, because this is how we're going to get paid. This is your follow-up process to see if the claims have been paid or denied. Once your claim is submitted, then the follow-up process begins. You can begin to follow up on the process after 7 business days if your claim was submitted electronically, considering the electronic submission is faster route to go. Although please keep in mind that not all of your claims will be able to be submitted electronically. It really depends on the insurance company and how they like them to be sent. When we have to send claims via paper through the mail, then we usually give it about 10 business days to see if the insurance company has received the claim. Sometimes when you call the insurance company, it's unfortunate, but sometimes they won't receive the claim ever. They'll just say they don't have the claim on file. So when you go to status a claim, it will say no claim on file, which in that case, you'll have to resubmit the claim all over again. And that's why it's very important to make sure that you're keeping up on everything in a timely manner, because it does come to a point where if you're not staying within a certain time frame, depending on the insurance company that you're working for or that you're billing for, things can be denied as timely filing. And when that happens, a lot of the times we will have no choice but to write off those, write off the timely filing, which means we won't get paid for it. So to start the follow-up process and checking the claim status of your claim, you would need to go on available websites to see if you were able to find the status of the claim. So some insurance companies will, we do have access to some websites, but unfortunately, some websites does not either provide all the information, or some insurance companies don't provide websites that we can go on and check the claim status. When going on the websites, there should be an option that states claim status, in which you can then put in the patient's name, you can put in the date of service, or you can put in the claim number. However, it will not always be that easy, like as I stated, considering that we might not have access to all insurance companies to check the status of the claim. Now, some insurance companies that we have access to, one of them is TRICARE, which I love that insurance because we are able to go on the website. We are able to either check claim status. If we find out that the claim paid, we can then, it does give us an option to pull the full EOB off of the website, which is nice because then we can send it over to our payment posters and we can go ahead and get that claim posted, and that will take it off of our AR, so we will no longer have to worry about it, and we'll be able to see exactly what all happened with that claim, which is very nice when we have insurance websites that will allow us to do that. So now if we cannot check the claim status on the website, then we'll have to call the insurance company directly. So when calling the insurance company, you need to make sure that you have your tax ID ready, along with your MPI number, the patient's name, date of birth, the date of service, and bill amounts. So this is everything that the insurance company will expect you to have. A lot of the times when you call the insurance companies, it will be an automatic system. You'll have to keep pressing numbers that ask you to put your MPI in and ask you if you want to do claim status. So sometimes you could just go through the automatic way. You can select claim status as one of the options. Then it asks you your questions, MPI, patient's name, date of service. It asks you all that. But then if you still have questions, then you can go ahead and hit the option it gives you to be connected to a representative. Once you get to know your insurances, it's also important to know the times of day to call them, because there are insurances that you'll come across that has a high call volume, which you can be on hold for a very, very long time. There's been times myself where I've been on hold for a good half hour, 45 minutes, just waiting to talk to a representative. So sometimes if you know your insurances and you know they are very notorious for having high call volumes, it's better to call them first thing in the morning when they open up. And another good thing, sometimes it can also be best to call the insurance company versus trying to status a claim online, for the simple fact that the insurance company can, if you check your claim status and you find out that the claim was denied, then you can see what you need to do to get that claim paid. The representative will let you know exactly why it was denied. They'll tell you the steps that you need to take to get this claim paid. If there are steps that need to be taken, if it's a situation where the services are not covered and there's nothing you can do about it, then obviously we'll have to look further into that if we need to write off the claim or something, as well as that goes. Now, if there are stuff that denied, say there was a duplicate billing, I've seen those denials several times. That means that a claim was sent out twice, so they denied it because of that, or there's been times I've seen different denials that were none covered based on the services that were performed. The insurance company might not cover those services, or they might cover the services if you have a medical necessity, in which, if that's the case, then you can go on to get, we can have one of our doctors sign a medical necessity saying that this was a necessity for the patient to have this service, and then the insurance will review it and they can pay it. So it is beneficial sometimes to contact the insurance directly versus the website. And once again, you'll get familiar with that as you work through your AR and you get familiar with these insurances. So here is our explanation of benefits. This is what we're going to need to look at if you want to see how the insurance company processes a claim. So this is what our EOB looks like. This is what we refer to. It would list the payer in the top left, which is Medicare B. It will list their address and all of that information. Then it will list the provider's name, which is us. That's also on the top left side. See, the EOB will show you the patient's name. It'll show you the date of service, which is off to the left. It's going to show you in the next column your place of service, which is number 11. which is a physician's office, is where this service took place. It's going to show you your procedure codes or your HIPAA codes. And then next to that, you'll have your billed amount. And your billed amount is going to be the charges that we charge for our services. And then we have our allowed amount. And the allowed amount is going to be what the insurance company had allowed. We have our deductible, and in this case, if you look at the EOB, there's no deductible. We have the coinsurance. So it does show a coinsurance of $38.63. Over to the right, if you look next to that, there's a code. It's a CO45 code. When you look down at the bottom, it's contractual obligations. So for the amount of $237.85 over to the right of that code, we would be able to actually, the payment posters would be able to adjust that code off, considering this is a contract with the patient and the provider to it's like a discount. It's a contract between the insurance company and the patient. I'm sorry, but yeah, it's a discount. So the patient or the insurance company will not be billed for that. And then over to the right, we have our provider payments, what the insurance paid. There are some group numbers over at the top. There's other codes that are MOA, there's MA18, MA01. So when you look at an EOB, you have to look at the whole process of the EOB. So when we look at this claim, this was a Medicare B. And as we talked before regarding insurances, Medicare sometimes will cross over a claim. And it looks like this is the case. So when we looked at the bottom, we see claim information was forwarded to Blue Cross Blue Shield. So that's who the patient should have listed as their secondary. Sometimes that might not always be the case. There could be an issue where, again, the patient did not update their insurance, but they're going to send this claim to Blue Cross Blue Shield. Now, if that's not really the insurance that's in the system, the insurance will deny the claim. Blue Cross will deny the claim saying, hey, we're no longer their payer, and they'll send it back to us, and we'll have to call the patient, get the information, have them updated. If the patient lost the insurance or the insurance was termed, then the patient would be responsible for the coinsurance that's listed on the EOB. So let's see. The EOB also provides us with our provider number, which a lot of times it'd be our NPI. Sometimes you'll see the tax ID number be listed on the EOB. It'll show the page number. This can be important sometimes when you get EOBs because like if you go online and you status a claim and you see there's like pages 1 out of 3, you're going to want to have all 3 of those pages to see what's going on, to see what denied, what not denied. You might have everything paid, which is the part of the payment poster's responsibility. Everything would have paid, but then your denial could be on the 3rd page. So you want to make sure you have all your pages. You'll have the date of the check listed on the EOB, and you'll have the check number listed on the EOB. And so this is also important. So let's go over some of these codes down here at the bottom. So you've got the MA01 code. If you do not agree with what we approved for these services, you may appeal our decision. To make sure we are fair to you, we require another additional that did, which it looks like part of that is actually cut off. So, but this is telling us that if you're not okay with the decision that was made on this claim, you do have the right to appeal it. You will see some EOBs that will say that this claim may not be appealed. So in that case, there's really not a whole lot that you can do with that. We have our 45, which was the CO45, which is charged. And this was a charge exceeds your contracted legislation fee arrangement. So that amount was adjusted off because those charges are not due. It exceeded their allowable amount pretty much. So you got your MA-18. The claim information is also being forwarded to the patient's supplementer insurer. So that's just telling you that the claim is being forwarded to the other insurance company. And then if you have any questions regarding the supplemental benefits, then you can send it to them. And then you have your CO, which is your contractual obligation, which I talked about before. That's the discount that was agreed upon between the provider, or I'm sorry, the patient and the insurance company, in which case the patient or the insurance company would not owe for those services. So in this part of the presentation, I want to go over the appeals with you guys. So this is when a claim denies and you have the belief that it should not have been denied. This will involve fighting the denial and filling out a lot of paperwork. So you're going to fight the denial with the insurance company. Because as I mentioned before, the insurance company will try to fight payments some of the times, and some of the times, especially when you get familiar with AR, you will start to determine, okay, no, they should have paid for this, and you'll get more familiar with that. So the appeal process can be a very effective way to resolve and receive payments for your claims that are denied for reasons other than for simple registration errors. Before filing an appeal, we want to review the denial to see if the claim should have been truly denied or paid. When you get further into working AR, like I said, you'll get more familiar with the insurance companies and what procedures should be paid on and what should not. However, until then, it is always a good idea to look further into the denial by calling the insurance company to see why they are denying this claim, to get a better understanding of their guidelines. You can also check with the insurance company to see if there is anything we can do to get this denial paid without having to go through the appeals process. There's a lot of situations you will come across where an insurance company, as I mentioned, can be a bit challenging, and they'll fight you on making the payment. However, if you are not able to get the denial resolved and you truly believe this is a service that we should have received reimbursement for, then you can seek direction from the insurance company to initiate the appeal or reconsideration process. If you are dealing with a commercial payer, the payer might have a reconsideration form on the website that we can use to challenge the payment decision. Writing an appeal letter can take time, and then it takes even more time for the recipient to read the letter, verify the argument, and then forward the claim to be corrected. If the problem is simple, you may be able to have the claim sent back simply by calling the payer. So like if it's a simple problem you can fix, you can call the payer, find out what you gotta do, go ahead and do what you need to do, resubmit the claim. So when the issue cannot be resolved over the phone, then you will need to write an appeal letter and state your claim as to why the insurance should not have denied services. You would need to make sure you have all your backup documentation to support your claim and a justifiable reason. So when you go to submit your appeal, you need to get everything in order, like whether, like, let's say the insurance company has paid on this before, or, any evidence that you have, you need to document the phone calls that you made with the insurance companies. You need to document everything and submit it with your appeals to help back you up when you're trying to fight for the payment. So please note that if a claim is under $10, we do not waste our time filing an appeal. It takes time and money to file an appeal and is not worth it if we end up spending more money than what the claim is actually worth. $10 is kind of it's kind of on the borderline. We know definitely anything under $10 we don't want to send an appeal for, but sometimes it's best to kind of run it through to me first if you're kind of within that balance, just to kind of see if it's worth our time. So if we did not get paid for these services, the ones that are under $10, then and we know that it's either due an appeal or, I mean, that's pretty much our only option. Um, then we will write off the balance in the system as a write-off small balance. Our time here is valuable as well, so we need to make sure we are efficient on keeping up with all of our other tasks as a medical professional. So this is a decision that needs to be made by you. And if you are unsure, you should start the process of an appeal. You can run the issue by me as your manager, and I will guide you on what the best option is. Because as I stated, appeals can be very timely. It's a lot, it's paperwork you got to fill out, it's extra work you got to fill out, and it takes away time from doing your other daily activities that you need to be doing. So that's why we need to make sure that we have all of our ducks in a row, that we're really needing to appeal the decision, and that this truly was not supposed to be a denial. We need to make sure that we know that for a fact. And as you're doing AR, you'll get more familiar with everything, and you'll get familiar with what the insurance companies are paying, what they're supposed to be paying, what they're allowing, what they're not allowing. Like, for instance, if you've got a Blue Cross and you know for a fact that if you've got a code that's let's just say a diagnosis code of 9996, or something in that matter, E0431, a HIPAA code. If you see those codes and you know that it should be paid for because it's a simple code or something, then you will need to, then that's when you want to make sure that you do an appeals process, because you're definitely sure, and you'll get more familiar with that as you go along. So in this step of the training, I wanted to talk about the payment posting side of our office, because they do go hand in hand with AR. You guys will kind of work together as a team. There will be times that you'll have payments that, or you'll have payments that you see the insurance has paid, but they're not posted yet. So you have to work with the payment poster to kind of get an idea of why these payments were not posted yet. Same with denials. If you see there's, the insurance company denied, why did the denial not get posted to the account? So payment posting and AR kind of goes hand in hand, back and forth. If you need to locate an EOB, a lot of times the payment poster will be able to locate that EOB for you better than you're able to. Let's see. So the process of our payment posters is to post the payments we receive from the insurance companies or the patient, along with the co-insurance amounts, or along with transferring the co-insurance amounts, transferring the co-pays, and the deductibles that they are reading off the EOB. When a payment or denial is received, the payment poster will post their payments and follow the EOB. The sooner the payments can be received and posted, the better it is for many reasons. For instance, if a patient has two insurances, the secondary insurance will not get billed out until the primary payment is posted to the account. One exception to that, though, is if the primary insurance is Medicare and Medicare has crossover the claim to the next payer electronically, as we talked in a previous slide. So those get paid. The secondaries will get billed right away if that's the case. So that would mean that Medicare processed their payment, then they transfer the coinsurance to the secondary payer electronically, and we will get paid from the secondary payer shortly after that. It could take, maybe like 7 days. That's the great thing about electronic, is that we get our payments a lot faster. So, but always keep in mind that is not always the case, as Medicare does not cross over all their claims. Now, if the claims are not crossed over, and we have, we still have a balance on our primary, the secondary cannot get billed until that balance is taken off of the primary. So that's why it's very important to look into getting getting either payments posted timely, which is where a payment posting department falls into place, or it's important to get the claims paid, which is where you guys will fall into place with the ARs. We need to get everything efficiently. Everything that runs in our company is a whole process of efficiency, and how everything is done. So with that being said, so one thing to note is that on Medicare, okay, that one. So let's see, the payment poster will also post all the denials, which pop up in an AR report to be worked. An AR report, I kind of want to go over with you guys, will be very important to you as an AR worker because we can run a report that will list all the invoices that are still outstanding that we have not received payments for. So some denials are called denial allowable discrepancies. Those can show up on your AR reports. This means that the insurance paid, however, the insurance paid a small amount, so our payment poster left the remaining balances out there for the AR team to follow up on. If this is the case, then you guys will need to call the insurance company and find out why they paid such a little amount, and they need to see if the insurance company will reprocess the claim and pay more on the claims. If the insurance company has a justifiable reason for paying the amount they did, such as the benefit maximum has been reached, then the AR department will adjust off the remaining balance to close out the invoice. However, if the claim was underpaid, then the AR department will talk to the insurance company about that, find out why it was underpaid, and then you guys as the AR workers can send out what we call a reprocessed claim. So you'll send that out, the claim will be reprocessed, and then the insurance company will come back and they'll make payment on the claim, in which our payment posters can then post the additional amount and they can adjust it off. Now, as I talked about on this one, I talked about the paid reports, or they are paid reports. These are main things that you guys are going to be working on too as well, because this gives us a good idea of how many outstanding payments are out there that are not posted. That might not always be the case. There's also situations where there's, let's just say, 5 procedure codes on an EOB. 3 of the procedure codes paid, 2 of them denied. Those are going to show up in your paid reports. So that way, when you look at them, you're like, okay, well, why these ones pay and the other ones denied? In those situations, you'll have to call the insurance company and find out why. So it's a whole big process. Payment posting, as I mentioned, goes hand in hand with AR. You're going to need them a lot. You're going to be making phone calls because there are times our payment posters, you might see that the insurance company had made a payment, but you're not seeing this posted on the account. You can go over to the payment poster, they can look into it, and it could be a situation where the payment poster received the payment, but they posted it to the wrong date of service. That happens in some cases as well. In that case, the payment poster would then do a correction on that claim to take it off of the date of service they posted it to, and then they'll go ahead and post it to the correct date of service. So I just wanted to give you guys a little insight of how the payment posting department works. So when you do have issues, you can go to them as well regarding any EOBs or any payments, and they can assist you with that. So we are at the end of our training. I wanted to give you a summary of our training to kind of go over what we covered. So we have the life cycle of a claim, different types of insurances. We have accounts receivable, which is you guys, AR. We have our AR age buckets, our CMS 1500 form, a clearinghouse, claim status, EOB, appeals, payment posting, rejections and denials, and HIPAA. So I hope everything we went over with helps give you the knowledge you need in order to succeed in our company as an AR worker. As I mentioned, the first thing we talked about is the life of a claim cycle and how it works. You will regenerate a claim once the patient has been seen in our facility. Then you can bill out the claim. You can then follow up on the claim. Within a time frame, we should receive reimbursement for our services. if the claims get approved. The poster will then post the payments in which the claim will no longer be open on your AR. We talked about the different types of Medicare and insurances. As I stated, once you start working, you'll become more familiar with these insurances, which will help you be more efficient when working AR. Remember, as an AR worker, it is your job to regenerate the claims and submit them for reimbursement, along with following up on the claims. You want to make sure you are checking your age buckets and trying to stay within the 0 to 30 days to increase revenue. I know sometimes it can be out of your hands, considering some payers might take quite some time before processing the claim, but I do believe persistence will help get the claim processed timely. And we went over our CMS 1500 form. This is the form you will need to submit in order to receive reimbursement. If you are unsure of how to fill it out or want me to walk you through the process, I would be more than willing to help. We talked about the clearinghouse and how when we submit our claims, they go through the clearinghouse, Zermed, to be checked for errors before it is sent to the insurance company. As an AR worker, you will need to follow up on your claims by checking the claim status. You can do this on the website if you have a website for specific insurance, or you can call the insurance company directly to get the status. We went over the EOB. This is very important in AR because you will need to look at the EOB at times when you receive denials to see why the insurance company denied the claim. We went over the process of appeals. Remember to keep in mind that when you appeal a claim, you need to make sure you have all your supporting documentation ready to fight the decision made by the insurance company. And you want to also make sure that it's worth it. We talked about payment posting and how they play a role in making your job a bit easier. We also discussed rejections and denials, which is a very important aspect of accounts receivable. And we talked about the importance of HIPAA. So it's going to take a lot of time to get the training in process. And I am one, I'm definitely a hands-on person. So once you get how everything works, I have confidence that you'll be able to succeed in the AR field. I'm here if you have any further questions. I'm here to help. You will also be working with some other AR workers to who will do some additional training with you. So thank you again for for attending this training session. I hope this helps guide you and gives you a better insight of what needs to be done in the AR field as far as billing goes.